So, very good evening to all my seniors, colleagues, and juniors. Today's evening is we have planned another class of series of UROCONNECT classes. That is the morning class. So, this topic of discussion, a very burning hot topic in our urology practice, that is regarding laparoscopy. Institute of Nephrology and Urology, Hyderabad. We were fortunate enough very recently to see him operate in a workshop in Calcutta Medical College. Without further ado, I would like to hand over the session to Dr. Ghouse.
Thank you,
Yeah,
Sayak, and thank you, Prasanna sir, for giving me this opportunity. Hope I am audible and my PPT is visible. Yeah. So I was very fortunate to recently visit Bengal Urology Society and a nice workshop at the Government Medical College, the oldest college in Asia, and happy to do a partial nephrectomy and a bori flap and assist a lab radical prostatectomy. It was a really very, very nice experience there. So coming back to laparoscopy, basically laparoscopy is basically a passion. Though I do a lot of robotic surgery nowadays, but laparoscopy is a passion. If one has to pursue doing good amount of laparoscopy, one has to good amount of urology, one has to have good laparoscopic skills. Though one needs to learn robotic, but robotic is nothing but again a laparoscopy with a probably with the help of a robot. So one needs to have a basic laparoscopic training and basic laparoscopic orientation for even doing a robotic is what I feel. People have a notion that you can do robotic and just transit from open to robotic, but still I feel laparoscopy is the basic that is required even for a robotic surgery. So coming to the basic, the importance of laparoscopy is lies in the ergonomics of laparoscopy. So for doing any comfortable laparoscopy, one needs to know about the ergonomics that are involved in a laparoscopic view. My cursor is not moving here. So this is a small cartoon where it says rather than making the dad, bend down to meet you, you should be easy enough for the dad to meet you comfortably. So what does it mean? So, whenever you want to do laparoscopy, you have to be so comfortable that you should not feel that you are doing something which is anatomically correct. You are not doing it in a very crooked manner in such a way that at the end of the surgery you should not start feeling exhausted. You should not have injuries related to doing laparoscopy. So to tell this, there is a paper which is published in American College of Surgeons which says that almost 90% of surgeons, when they do laparoscopy regularly, they tend to have some sort of injury on their in a different musculoskeletal injuries as and how they keep doing laparoscopy for a longer duration. What are these injuries that regularly happen? These are neck pain, spondylitis, laparoscopic shoulder, laparoscopic thumb. These are described entities in laparoscopy that happen when you do a regular laparoscopy for a longer duration. Hand muscle injuries, stress exhaustion, tenosynovitis. Malik sir has got a trigger finger. He has got tenosynovitis of the flexor brevis. So these are injuries that regularly happen. Dr. George P. Abraham had a laparoscopic spine because of long-standing surgeries that he used to do, for so many years. So what if all of us are aware of good amount of laparoscopy or urology in India, one should be able to pick up the people who are there in this photo. Anyone from the audience, some 18, 19 audience, I am able to see who can pick up who this person is in the photo on the right side. Anyone?
Abraham, Judge Abraham, I believe. No,
No, no, sir, no, sir.
no, no,
So
no, 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 no.
this is a photo taken. This is a photo taken from his own presentation. This is Dr. Rajesh Ahlawat
Which is the right one? Even
with
the left one.
the
The
one with
left
an
one with the
injury.
cervical color.
Yeah, the one with an injury. So that he is a pioneer in laparoscopic surgery in India in urology. In fact, he is one of the first persons who has done a laparoscopic recipient in a transplant. So he is a person who has devised how to do conveniently, comfortably a robotic transplant also. But see, his own brothers, those two other people are his own brothers, and see what laparoscopy has given it to him. So when somebody is doing a laparoscopy for long duration, you get all sorts of injuries. So to avoid these injuries, one needs to, however, ergonomically, one has to do a laparoscopy. So why actually there is so much of issue about ergonomics in laparoscopy is you have some limitations, inherent limitations of laparoscopy that happen because of its own issues. Like there is loss of depth perception. You always see on a flat screen which is two-dimensional. The third dimension of depth is lost in laparoscopy, and all your movements happen at a fulcrum. What is a fulcrum? Whenever you do laparoscopy, there is an instrument that is put through the port, and so the center of the port acts as a fulcrum, and you have a place where you move your instrument at one end, the instrument moves at the other end. So this fulcrum effect is inherent of any laparoscopy. There is tremor enhancement. Suppose you had a good cup of coffee, or you had some sort of a caffeine. So whenever you move, there is enhancement because you are doing it through a long chopstick, almost 30-40 centimeter of an instrument, which is there pointing at an organ deep inside the abdomen, and you are moving it outside, 15-20 centimeters outside the abdomen. So there is a enhancement of tremor that happens at your hand, which gets exaggerated at the tip of the instrument. There are only 4 degrees of movement that you can do: up, down, medial, lateral, and rotation inward and outside. So these are the only four movements that one can do. Because of these limitations of laparoscopy, you have you develop a lot of stress and all these injuries in laparoscopy. So how do you overcome this inherent limitations of laparoscopy? What all you can change or to make this laparoscopy comfortable and easy? So you can change the patient's position, you can change the height of the OT table, though you cannot change the height of the surgeon, but in fact you can put some stool and increase the virtual height of a surgeon. Handle grip, you can decide as to which sort of an handle you can use: pistol handle, sword handle, pen, type of a handle of an instrument, or a ringed handle. What all instruments you can plan for doing an ergonomically laparoscopy you can plan. Length of the hand instruments, you cannot do a pediatric pyeloplasty using an adult instrument, so you need to have a proper length of the hand instruments. And then angle of the hand instruments. So all this, what at what angle these instruments are entering inside the abdomen to do a laparoscopy comfortably. Everybody is following,
Sir,
or you
sir,
need to
sir,
give some
Dr.
more?
Sayak here, sir.
Yes, I.
Sir, just interrupting a little bit, sir. For all the persons who are listening,
Mm-hmm.
you if you have any question, you can put them in the chat box. We'll put forward them to sir at the end of the presentation. Thank you.
Yeah. Um,
So you can continue, sir.
I don't know how I landed up here. Mhm. I lost the screen. Let me come back again. Mm, yeah. Able to see the screen?
Yes, sir, we are able to see.
Yeah. So where was I? We were talking about what we can change in a regular laparoscopy to make our life comfortable, doing long surgeries in a comfortable way. So what are the different aspects that we can change? The first one is the height of the table or the height of the surgeon. Again, what all I am telling is not from my own experience, but these are studies that have been conducted over a long duration of time, and they have come to some conclusion that that's what I am talking. So they have seen that the optimum height of the laparoscopic table should be at the level of the surgeon who is standing next to it, to the level of his navel or the umbilicus of the surgeon. So that is when you can do a comfortable laparoscopic surgery. Too low a table or too high a table, you tend to lift your hands, and you cannot lift and do your hands with your elbows away from your body for long, not more than 5 to 10 minutes in laparoscopy. So one needs to have a table at an optimal distance. What is that optimal distance? It should be at the level of your umbilicus or your navel level. The next comes to different handles. This is again an experiment which was done wherein they have plastered or applied a POP at the elbow so that the angle at the elbow should be 90 degrees. Why 90 degrees? That is the normal resting angle at our elbows. We never sit on a table with our outstretched hand, neither we sit with our hands flexed at the elbow. So that is our resting angle of 90 degrees at the elbow. So what they have done is they have put up POP plaster onto the surgeon and given him different hand instruments. So what they have seen is when a surgeon holds a shank handle, when a surgeon holds a pistol handle, when an axial handle instrument is held, there are different heights of the OT table that needs to be adjusted for different handles of the instruments one uses. Hope I'm able to tell what I'm trying to convey. See, what I mean to say is, if you are holding a shank handle, you will hold the handle from below. So for that, the OT table has to go up. Otherwise, you will bend below and try to hold it. Supposing you are holding an axial handle, you will hold the instrument from above. So that means if the table is quite high up, you will yourself stretch yourself and lift your arm away from your body to hold that axial handle instrument. So for that, the table has to go down. So when the angle at the elbow is fixed, which is the resting angle of 90 degrees, your table has to be adjusted depending on what type of instrument you are holding. Hope I'm clear. Please stop me for any questions in between itself so that we will go as and how you are able to follow. The second thing is intracorporeal and an extracorporeal length of any laparoscopic instrument. Anybody, what is the length of the laparoscopic instrument, the common laparoscopic adult instruments? What is the length of the instrument?
30, sir.
Yeah.
30.
So 30 to 35 centimeters is the length of any laparoscopic instrument. The 3 to 5 centimeters is the length of the handle. So you assume that the instrument is 30 centimeters. Okay. So if the instrument is 30 centimeters, you are putting the instruments inside the abdomen. The length of the instrument which is there inside the abdomen versus the length which is there outside the abdomen has to be equal for a proper movement to happen at the fulcrum which is there in the center of the abdomen. Hope I'm clear.
Yes, sir.
Yeah, what happens is when your instrument is quite far away outside and only a part of the instrument is inside the abdomen, you will have to move a large distance outside to move a small distance inside. That is because the fulcrum is at the tip of the instrument. Majority of the 80% of the instrument is outside. This happens if you are using an adult instrument for a pediatric pyeloplasty or a pediatric nephrectomy, where the inside distance from the effector organ to your fulcrum or the abdomen is very less. The pediatric abdomen does not distend very much, so your distance inside is less, where the distance outside is more if you use an adult instrument for a pediatric case. So what happens is you need to move 10 centimeters outside to move 1 or 2 centimeters inside with the tip of the instrument. So whenever you need to do any laparoscopic surgery, you need to have inside distance equivalent to the outside distance of any laparoscopic instrument. So I have asked what is the length of the laparoscopic instrument. So it is 30 centimeters. So the midpoint should be 15 centimeters. 15 centimeters should be inside, 15 centimeters should be outside. That is when whatever you movement you are doing outside, same amount of movement happens at the tip of the instrument inside. So this type of movement or this type of thing is known as the type 1 lever. This type of lever is type 1 lever, where the fulcrum is in the center. What all load is given, same effort is transmitted to the tip of the instrument. Hope I'm clear. So these are the few
So,
examples. Yeah.
so your full screen is getting cut from the side, sir. So,
Phone screen.
the entire thing is not getting seen, sir.
Oh, 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 oh. Why does that happen? Mm-hmm.
So you can just do it again, sir.
How is it now?
Yeah, now it's fine, sir. Now it's fine.
Yeah. So what I was showing is the length of the instrument inside versus length of the instrument outside. Intracorporeal versus extracorporeal length should be equal. When you have a 30 centimeter laparoscopic adult instrument, you should have 15 centimeters inside, 15 centimeters outside. A few angles that one needs to know. One is the azimuth angle, that is the angle between our optics, or the camera, and the angle of the working instrument. So this is known as the angle. What is manipulation angle? That is the angle between the two working instruments that we use. What angle they make at the tip of the instrument, that is the manipulation angle. Basically, how will you manipulate with those two instruments? That is a manipulation angle. Elevation angle is from the horizontal of the table or the horizontal of the floor, how much your instrument is elevated so that you are entering at that particular point inside the abdomen. Why are these angles important is, when the angle of manipulation increases, your hands tends to get elevated from your arms, and this laparoscopy becomes very difficult to do. Though you are putting ports comfortably away from each other without clashing, but you are tend to move your hands up and you tend to do laparoscopy with a lot of cumbersome way, and that is not ergonomically correct. So they have again studied and seen that the manipulation angle, when it is 60 degrees, that means when the two working instruments make an angle of 60 degrees at its tip, that is the optimum angle through which you can do maximum amount of work with the least amount of time. See this graph, the time taken versus the angle. So the different angles people have put ports, 30-degree angle between these instruments, 60-degree angle between the instrument, 90-degree and 120-degree. So they have seen that same task by the same surgeon can comfortably be done in the least possible time when the manipulation angle is 60 degrees. So few things we have learned is, depending on the height of the table, height of the surgeon, how much of instrument has to be inside, how much of outside, what should be the angle of manipulation, and what sort of an instrument. So why this angle of 60 degrees is important? Why cannot it be 90 degrees? Why cannot it be 180 degrees? Because our again natural way of doing anything is, or when we sit comfortably, see whoever is sitting there watching the screen now on their laptop or the screen, you are sitting with your arms, elbows as 90 degrees, your arms not abducted but adducted and touching your body torso, and your when your fingers are free, they reach to each other at 60 degrees. So that is our resting position. We don't sit like this, neither we sit like this. We sit with our arms adducted, with our elbows at 90 degrees or beyond, and our fingers touching each other. So this is a normal resting position of any human being. So when they rest, these two hands meet at 60 degrees. So we want this angle to be transmitted inside the abdomen to form a 60-degree angle. So this is the angle at which you can do 1 hour, 2 hour, 3 hour surgery comfortably without straining any of your joints or muscles. So just remember, whenever you are eating your breakfast with a fork and a knife, or a fork or a spoon, you see what angle these two instruments are making while eating. So they make an angle of 60 degrees because that is ergonomically correct. That is evolved over a period of so many ages that you land up making an angle of 60 degrees. So same angle has to be again replicated in laparoscopy to do it comfortably. And one more thing is, there is something known as gesture impression. If somebody who are attending now, if they have attended the conference on this weekend, they would have seen that there were two ports that were placed for doing the suturing in a laparoscopic radical prostatectomy, one 10 and one 5 Why we use 10 and a 5 10 is to put the needles inside, or a clip applicator that goes through a 10 and a 5 to suture. We have a needle holder which is not 10 we have a needle holder which is 5 So whenever you put a 10 cannula and use a 5 instrument through it, the fulcrum which was supposed to be there at the center of the instrument making 15 centimeters in and out, that fulcrum keeps jumping. Suppose this is a cannula from this end to this end, the fulcrum keeps jumping from the proximal end to the distal end, distal end to the proximal end whenever you do any movement, and that is where the instrument touches this point or instrument touches this point. So though the instrument is 15 centimeters inside and 15 centimeters outside, now the fulcrum keeps jumping whenever you have a 10 trocar and a 5 instrument through it. So because the fulcrum keeps jumping, your tremor which is there outside gets exaggerated. This is known as gesture imprecision. So to avoid this, always have a 5 port with a 5 instrument through it, so that the entire instrument and the trocar are in contact, and you have a fulcrum at the center of the instrument only. Hope I have conveyed. Next comes the grip. So different ways of holding the instrument. The best way is a relaxed grip. We can hold the instrument well with putting our fingers in the rings that are given. But just imagine yourself doing general surgery or an open procedure wherein in first year of your general surgery or internship, final year of MBBS, you tend to put your fingers inside the needle holder and then try to suture. Any scalp injuries, you would have remembered how you suture with your all your fingers inside the rings of the needle holder. By the time you reach the final year of general surgery or you become a professor, assistant professor, you tend to remove your fingers out of the instrument. You no more keep the fingers inside the rings of an open instrument. Same is with laparoscopy. You should not put, the tendency is go back and when you start doing laparoscopy again, see whether you are putting your fingers inside or outside. See this figure on the left side. I'm not able to point here, the finger with an orange instrument. See that only one finger is outside. The thenar eminence is the place where your instrument, the other ring of the instrument has to be placed. No thumb inside. It should always be the thenar eminence and your fingers in one of the fingers through the other ring of the instrument. So this is the ergonomic grip one needs to have to rotate the instrument in all directions. Because this is a virtual meeting, I am not able to show you with the laparoscopic equipment, but that is how it is supposed to be held. Supposing you are using a hook where it's just a rod, so you should hold it like a pen. If it is a laparoscopy, you should hold it with a thenar eminence as shown here, or when you are using a hook, you need to hold it like this. Supposing you put a port quite medial and you are trying to do an instrument, trying to do a area of dissection which is away, then your hand needs to go down. In that situation, you can rotate the handle up and you can hold it on the top image you can see there. So this is when you put a port already quite low and trying to manipulate from there. But again, no fingers in the rings of any laparoscopic equipment to do it properly or ergonomically. What happens if you put an instrument, if you put your fingers in the rings of the laparoscopic instrument, is your wrist get fixed. You will not be able to rotate it comfortably because once your fingers are inside, the rotation does not happen. Your wrist gets fixed. So what is the optimum situation to do laparoscopy? So if you have a monitor, majority of them you would, if you would have seen during the conference also, always you have a trolley in any hospital, any nursing home, any college. You have a 6 feet tall trolley on which your laparoscopic monitor of 31 inches or a 26 inches is placed. So always first of all, none of us except I think Sayak and few guys who are 6 plus, all of us are around 5'5", 5'8", fine. We are not 6 feet or 7 feet guys who are having a angle of view in level with the trolley which is available, laparoscopic trolley. So all our trolleys need to be, or the monitor should be in such a level that we have a eye to eye gaze, or the monitor should be at the level of our eyes or slightly below, that is 15 degrees or 20 degrees below our gaze. We don't generally don't speak to each other looking at their head. We speak to each other with their eye contact. So whenever we are doing laparoscopy, the same has to be replicated. We should not be seeing the monitor which is above a 6 feet trolley, almost 7 to 7.5 feet, and with our neck extended. If you do laparoscopy for long, you will have neck injury, and you have seen in the photo how Dr. Rajesh Ailawat has got a neck injury and he is wearing a neck collar. So always have your monitor at the level of your eyes or slightly lower gaze. Arms by the side, as we have just discussed, arms should not get elevated. They should be near your torso, because with your arms elevated, try to do any laparoscopic surgery coming few cases and see you cannot do surgery for more than 15 to 20 minutes because your arms, because the deltoid starts paining and you tend to go back to its normal position. A relaxed hand grip. You should not be gripping with your fingers inside the rings of a laparoscopic equipment. Rather, you should hold it like how we have just discussed. Supposing you are seeing, all of you would have gone to different theaters to watch movies. Why is the lighting inside the theater dimmed or switched off to see the screen? That is so that the screen, whatever is shown on the screen, becomes more crisp, more clear. So the same reason one has to dim the lights in the operation theater, so that whatever you are seeing on a screen of the monitor should be very crisp and clear. If you have a bright light source or a display behind it, you will not see it so well. Similar example is, see, if you are seeing my photo now with a display which is illuminated behind me, my face becomes very dark. Hope all of you are appreciating that. Hello.
Yes, sir.
Yes, sir. Yes, sir. We can see that.
Yeah, my face become very dark. The same thing, you should have your OT which is subdued. Your lighting should be subdued, and better to have a blue light which is more soothing to the eyes to do a long laparoscopic surgery. Then ports have to be at a neutral wrist position, elbow position, and the manipulation angle that we just discussed. And the instrument should be 50% inside, 50% outside. Operating table should be at the pubic height of a non-obese patient. So these are all the optimum situations that are required to do a ergonomic laparoscopy. Hope I'm clear. We will
Yes,
skip
sir.
we will skip this part of creating a pneumoperitoneum. We will directly go to port placement, because my topic of discussion today is how to access the kidney and the ureter for its surgery, right? So let us discuss about ergonomics in port positioning. All of you would have read in the textbooks of laparoscopy as to how do you put a port for any laparoscopic procedure. You follow a rhomboid or a baseball pitch technique. What is this baseball pitch? Nobody knows. Basically, it is a angle that is made by your two working instruments at an angle of 60 degrees manipulation angle on the target organ which is there inside the abdomen, with the 50% of the instrument inside, with the 50% of the instrument outside, with your arms by the side, you standing comfortably at the on the table at your pubic symphysis, with your elbows 90 degrees and your hand at the resting position. These are all, when they are met, that is where it forms a rhomboid, or many people show in this way. If your instruments are meeting on, you make a you make a diagram like this onto the abdomen. This is a target organ. This should be your camera port, and these two, what do you call this, snuff boxes. This is the area where your ports have to be. This is what they generally tell. So what decides where to put a port? It depends on the target organ of interest. It depends on the truncal habitus. Patient is scaphoid, where patient is a Paris lady with lot of pannus, or position of the umbilicus, abdominal distensibility, a young male versus a multiparous female, and the previous scars. Suppose if there's a battlefield abdomen, previous, you know, Whipple surgery was done, previous appendicectomy is done, multiple cesareans have been done, lap cholecystectomy is done. So how the abdominal scars are and the abdominal vasculature. So all these things decide how to put a port, with all our discussion that we had till now also in our mind when we are putting a port. Supposing a situation is there where we are doing a right-sided upper polar renal tumor. So this is how a typical port placement needs to be. Same right side, but you have got a large PUJO, a large renal pelvis with a PUJO. So this is how your port configuration is going to be. Also, the angle with which your target organ is made with your instrument decides as to where the target organ is. Like for example, if you have got a pediatric case on the left side, you can see a small abdomen which does not distend after an hemoperitoneum, versus an abdomen which is going to distend massively after, once you are creating an hemoperitoneum. So never mark any port before you make any pneumoperitoneum. It is very commonly seen in, even in conferences, that people mark all the ports. This is going to my right hand port, this is my camera port, this is going to my left hand port, and then they create a pneumoperitoneum. All these ports go away from each other because the abdomen stretches. Almost 3 to 3.5 liters of carbon dioxide is filled inside the abdomen. Everything stretches out. Now they struggle to do with the same ports that have been marked to reach the target organ. So always mark the ports only after creating the pneumoperitoneum. So this is a regular example which I give. If you have got a happy birthday balloon, before you fill the balloon, you would have seen that happy and birthday will be written just next to each other, isn't it? But once you fill the balloon, you can see that happy goes on one side and the birthday goes on the other side. So abdomen distance in all the directions. Your ports which you were marked before the pneumoperitoneum was created now go away from each other, and see what has happened in this image. All the ports have become crowded onto one side just to reach a organ which is there on the below the costal margin. Next comes the vascular landmarks in the previous scar. It is always good habit to know the surface marking of all the vascular structures. But also be careful about the previous scars. One has to be minimum of 5 to 8 centimeters away from a previous scar to prevent any injury for you with your port placement. So how to place the first port? It is always good to create an hemoperitoneum and increase the pressure more than the pressure that you require to do the surgery. For example, if you are trying to do the surgery at 14 or 15 millimeters mercury, make the pressure 17 or 18 only for the first port. Why is that? Because once you make the first port, before making the first port, if you increase the pressure by 1 millimeters of mercury, the distance between the anterabdominal wall and the great vessels, the aorta and the IVC, increases by 5 to 6 centimeters for every 1 millimeter increase in the pneumoperitoneum. That means if you are making the pressure from 15 to 17 or 15 to 18, the distance between the aorta and the anterabdominal wall increases by 8 to 10 centimeters. So you, even if you go in with some jerk, you have a space before hitting any major vessel. So slightly more pressure before creating the first trocar entry. So what are the do's and don'ts while putting a primary port? Wait till the adequate desired intra-abdominal pressure is reached. You have put a various needle, you are filling the abdomen. Wait for the abdominal pressure to increase to the desired pressure. You have set it on on the insufflator. See to it that the pressure is reached. Don't be in a hurry to put a primary port, because I just said the distance between the antra-abdominal wall and the major vessels increases after you reach the proper required desired pressure. Adequate skin incision. Don't put a small incision trying to be more cosmetic and try to push your trocar against a resistance of a smaller incision. Whenever you have a smaller incision, you tend to increase your force. When you increase your force, the amount of force which is required to stop the instrument from, or stop the trocar from hitting inside, will be less. So you will try to go with a jerk, and with the jerk you will try to injure something. So always have an adequate skin incision depending on how much your port that you're trying to place. Like for example, if you're trying to place a 10 port, you remove the trocar from inside, and with the cannula just compress it onto the abdomen. You will make a mark of the compression. Give an incision within that mark, so that when you put a trocar, it goes through and snugly fits through the skin incision. Safety index finger. Always hold the trocar in such a way that even if this goes with a jerk, it stops at this index finger and doesn't go beyond, so that you hit something inside the abdomen. Gentle rotatory movements. Check for the hissing gas which is coming out after you have inserted. Inspect the abdominal cavity whether you have injured something or you have gone through and through a small bowel loop and you are seeing beyond that loop. Things to avoid while post placement. We have just discussed. Do not use small incision. Camera port and working ports after complete insufflation only, and do not have ports with reference to fixed landmarks. Even in our textbooks, we have mentioned that so many 4-5 centimeters from the coastal line, 3-4 centimeters from the anterior superior iliac spine, so many centimeters from the mid umbilical point. These points are not fixed points. These points keeps changing depending on how the abdominal distensibility is. A small pediatric patients cannot have 4 to 5 centimeters or 10 centimeters from the coastal margin, because by the time you mark so much, his abdomen itself is over. Or a paras lady who has delivered 4 babies, her abdomen will distend in a different way. So you cannot have 4 centimeters. That will be hardly any distance from the area of interest. So no fixed bony points for any port placement. Always create an hemoperitoneum. Only then plan your ports. Port incision we have just discussed. I don't know why this marking is. So this is how a varus needle is being placed for a patient which is planned for a renal surgery. So two surgeries that we So two positions that we regularly do is, one is the kidney position, the other is the pelvic surgery. These are the only two positions that a urologist needs to know. And this is the kidney position. What we do is, on a line between the umbilicus to the anterior superior iliac spine, midway somewhere we put a varus needle. Once the insufflation is created, that is when you put in a port and see whether the gas is hissing out. So this is a repeat video of where the varus needle is placed, how a varus needle is placed against resistance from the abdomen. See that the saline is flowing comfortably. Once you connect the insufflator, there is low pressure and good flow. After your desired pressure is reached, that is when you put in the primary port. This is a varus needle placement for a pelvic surgery. Patient absolutely supine. See to it that rise tube and a Foley is in position. You put in the various needle supraumbilically with some sort of a towel clip or something holding the anterabdominal wall, freely flowing saline inside, connecting the carbon dioxide. Again, low pressure carbon dioxide initially. You have set a pressure of 15, but the pressure is only 4 or 5 when you enter the various needle, and the flow is good. Once you are reach the desired pressure, rotatory movements, hissing sound, and only then see whether you are gone inside properly, then only connect the pneumoperitoneum to the trocar. This is sectoring. This is generally followed for any pelvic surgery. Generally, gynecologists do it. What is this? Humans are tuned to have your head in between and right and left arm on either side of the head. But suppose you are doing with both the arms on one side, this is known as sectoring. This is generally done because cameraman holds the camera onto one side. You tend to put all your ports onto one side of the abdomen and do the surgery for pelvic surgery. Generally, this is followed by gynecologists to do because they cannot outstretch their other hand to reach the other side of the abdomen to do any pelvic surgery. So this is generally done in laparoscopy also by French surgeons, not by regular urologists that we are tuned to do. So these are the port placement for any pelvic surgery. Target organ is in the pubic symphysis or just below it. Supposing you are doing a VVF, you are doing a ureteric reimplantation, you are doing any bori flap, anything in the pelvis. This is how your configuration should be because your target organ is in the pelvis. The second thing you need to remember is pneumoperitoneum is created. Third thing is your instrument should be 15 centimeters inside, 15 centimeters outside. And the last thing is you should make an angle of 60 degrees at the tip of your instruments. So all these things, desired things, should be reached to make the port placement. So here the pneumoperitoneum is created. The patient's OT table is at the level of the pubic symphysis of the surgeon. Your target organ is defined. Now you make an angle of 60 degrees. Here you can see that there is an angle of 60 degrees marked with a protractor, and that 60-degree angle you just mark two lines going towards the head of the patient, right, and measure 15 centimeters from the target organ. The point where the 15 centimeter ends, that is where your instrument or working instruments or the port for the working instruments needs to be placed for any pelvic surgery. Am I clear?
Yes, sir. Yes, sir.
Chalo. What happens is you cannot have yourself standing at the head end of the patient for any pelvic surgery because you need to lean forward onto the patient's chest or abdomen to reach those points where you have just marked after pneumoperitoneum is curated. So what you tend to do, you tend to stand on the shoulder or on the side of the patient's shoulder onto the right on the or onto the left side. So what you do, you tend to change the entire angulation towards you, but the 60-degree remains the same, but from the midline probably the right sided degrees of angle should be less or the left side angle should be slightly more, but eventually you are going to make an angle of 60 degrees only at the area of on interest or organ of interest. So this is how a typical port placement is done for any robotic laparoscopic radical prostatectomy, radical cystectomy, VVF, ureteric implantation, bori flap, any of these. This is how typically any pelvic surgery is. I mean, what do you mean? The port placement is done. So now coming to different tocar entries. This is what I generally show. I showed it in the conference also. Whenever you are making the first port entry, always you can use this optical trocar. What is this optical trocar? You have a transparent or a translucent trocar through which you can put your camera. By seeing all the layers of the abdomen after creating the pneumoperitoneum, you can go into the abdomen, then remove the trocar and go back in. Second, you make a sufficient incision, you put in the trocar with the cannula, you start seeing the subcutaneous skin, subcutaneous tissue, that is the rectus sheath, white area of the rectus sheath, then the preperitoneal fat you will start seeing, then that is the white is the peritoneum and that is the inside the abdomen. Once you have reached inside the abdomen, now you remove the trocar and put your scope inside. So this is the optical trocar we generally follow for any laparoscopy before we put in a camera port. So this is the open trocar technique or a Hassan's technique, wherein generally used in a pediatric age group, wherein you give an incision.
Sir,
Yeah, please.
sir, you must have
বলছি ময়না
Hello? Anybody saying something?
No, sir, you can continue, sir.
Yeah. So this is an open trocar technique wherein a 5 mm trocar is being placed. Then a pneumoperitoneum is created. Under vision, you fix the rectus sheath. Also fix the skin to the trocar because the trocar is going to move. You have done an open technique, so the trocar is going to come out during your surgery once the camera is pulled back. So without to prevent it from pulling back, you fix the trocar also to the skin. This is open trocar technique. So there are few complications that can happen. Even though you follow all this, you can go through the bubble. So always have a vision inside after you have put in a first camera port. So this is a previously operated surgery, some sort of a peritonitis, and see my entry of the trocar was just next to the bubble. So always have a thorough look as to where you have entered, whether you have injured any bubble, whether you have injured any organ, you have created pneumo retroperitoneum or a pneumo preperitoneum, and see and survey your area before you are proceeding with the surgery. See, this was a donor nephrectomy. You have put in a varus, you have put in a first port, and this is what happens. You see a readout. You see a complete readout. What is readout? Your entire camera becomes red. This is what you see. So your varus is there inside. See again. Your varus is there inside. This is the first trocar that you have placed, and this is what you are seeing. Anybody, what has happened and what to do? Let us make it more interactive. What has happened and what needs to be done?
The varus has injured some vessel.
Yes.
So what vessel and where? Have to probably look inside to see possible after cleaning the telescope to see from where it's bleeding. Is it just a mesenteric injury or it's something more dangerous?
Yes. So basically it was a donor nephrectomy, left-sided. So what I've done is I've put in a first trocar and something is bubbling and blood is falling onto the scope itself. So you have still into the anterabdominal wall itself. I have injured the inferior mesentery, inferior epigastric vessel with a varus needle itself. My varus needle was so through the inferior epigastric artery that it is still bubbling through that artery. The blood is falling onto the scope which was entered, which has been put just next to the area of entry of the varus. So any bleeding, what one needs to learn is even in laparoscopy, even in open surgery, whenever something bleeds, what one needs to do? Just put pressure. Even an aortic bleed will stop or be controlled with a pressure. So first thing you should do is pressure. In this case, how are you putting the pressure? You are putting a hand onto the skin, and with the scope from inside I am pressing the scope or the endoscope or a laparoscope with a hand from above. So the inferior epigastric vessel is getting compressed between the scope inside and my hand outside. Hope I am clear. So anything when it bleeds, put a pressure, then take a deep what you can do. More important than that, what is one more thing? Anybody, if you would have noticed, what was done here? What was done here? That is most important. Any of the
Sir, you
participants?
have disconnected the pneumo, sir.
Okay. Disconnection of the Nemo will not help anything. In fact, I want the Nemo to be there because it
Okay.
adds as an additional pressure from inside. More important than that, very silly thing, it appears now, but that is the most important thing. My colleague was there, my anesthetist was there. I have asked him whether you have got a phone. Start recording of what I am doing now. Whenever
Okay,
there
sir.
is a complication, always record. Be it external, be it internal, always record. Because in a donor nephrectomy it is bleeding, first port placed, in a hurry you will put some gauze pieces, you will forget inside the abdomen. After 1 year patient will come with a legal notice. So always record what you are doing. Sorry. Always record whenever you are doing or you have got some complication. So this is a complication, you have injured the inferior epigastric, but the external view is not there. Camera is recording the endoscopic view. I have asked my anesthetist or my colleague, whoever is standing next to me, start recording, see what I am doing. So he has started recording. That recording I was able to show it to you. So what did we do? We opened, anyway we have to retrieve the kidney in a donor nephrectomy. We went till the peritoneum. We have peritoneum and underrun the inferior epigastric artery from both the sides. So because I could record, I could show it to you today, isn't it? So always record your complications. This is the underrunning of a inferior epigastric artery on both the sides, and we did not open the peritoneum. Peritoneum was intact. We continued with doing a donor nephrectomy. Solid organ injuries also can happen in laparoscopy whenever you put in a port with a previous lap cholecystectomy or a previous any abdominal adhesions that would have happened. Solid organs generally don't give any problem, just need to put some Surgicel over it and wait for it to stop. So to conclude, one has to evaluate thoroughly, examine the abdomen, do not depend on the imaging itself. Get adequately trained, discuss the indications, procedures, complications of the surgery with the patient, take an informed consent, take a consent for open if at all, during the surgery, you cannot go back and tell them, I need to open now. Take a 5 to 10% chances of conversion to open also for every case. No single access technique is safe. Somebody is used to doing an open Hassan's trocar technique only, use that. Somebody is used to doing a varus needle, do that. And surgeon should select the access which is the most comfortable for him. Don't just do that because somebody else is doing a varus, I should also start doing varus. No. And do not hesitate to open and take control of the situation whenever it is required. So this is a typical port placement for any upper renal surgery or a upper ureteric surgery in the form of a pyeloplasty or a nephrectomy or a partial nephrectomy. This is a typical port placement. What happens on right side is an additional port is placed crossing the midline to lift the liver. This is known as liver retraction port, which is placed quite opposite onto the other quadrant of the abdomen beyond the midline, because if you put onto the same side of the midline, it will come in your way of your right hand movement. So whenever you tend to depress your right hand, it is going to hit the liver retraction instrument that is placed on the midline. So always keep it onto the opposite side through the falciform ligament, come onto the liver, lift the liver, and then hold the diaphragmatic fibers. And also see to it that yourself, the patient, the monitor, all should be in the same line. Take an example from what you do in a daily life. You drive with yourself, your steering, your windshield, and your road all in same direction. You cannot drive comfortably, though you can train to drive, but you cannot drive by seeing outside through the window of the car and driving towards the road. That is not possible, though you can train yourself, but that is not possible. But just remember yourself whenever you go to any nursing home, or when you are doing a PCNL, all the urologists are trained to see the C-arm in one direction, to see the monitor in other direction, and to do the PCNL in this direction. Isn't it? Am I not correct? We are all tuned to do in different directions, but in laparoscopy already a brain is stressed out because of all the ergonomic factors, because of the 2D vision, because of the tremor enhancement, because of the fulcrum effect. All these things are already there, and you have a trolley, laparoscopic trolley on the head end of the patient, and you are operating onto the foot end of the patient, seeing that side, operating this side. Your brain has to again recalculate so many things to do a proper laparoscopic surgery. So ergonomically it is not correct. Yourself, your target organ, or a patient, and your monitor all should be in the same line. Then you can do a laparoscopy comfortably. Last but not the least, your foot pedals, all the foot pedals should be in one span of your leg. You should not be going and stretching to put a foot pedal foot put your foot on a pedal which is far away for a bipolar, far away on the left side for a monopolar, and far away again for a harmonic. All should be in one span of your foot. That means you should lift your foot, you should be bipolar. If you lift your foot, you should have monopolar. If you lift your foot, you should have harmonic. So that is how they should be planned and kept at your leg. Hope I am clear.
Yes, sir.
So this was a basic about how ergonomically one has to be placed to do any laparoscopy. Now few advanced things that I'll tell people who are already doing laparoscopy for long will understand this. What are these? In laparoscopy, there are few intuitive movements, few counterintuitive movements. Stop me, Sayak, whenever you feel that it is over time.
So you can continue, sir.
The last 10 minutes, I think. So
Yes,
what
sir.
happens is there are few intuitive movements, few counterintuitive movements in laparoscopy. What are intuitive movements? That is, when you are inserting an instrument inside the abdomen, your outside movement is replicated inside. You are moving it clockwise, the instrument also moves clockwise. You are moving it anti-clockwise, the instrument also moves anti-clockwise. But there are few counterintuitive movements. What are those? You are depressing the instrument here, but the tip of the instrument is going up. You are going medially inside, but you are outside, you are making it laterally. These are counterintuitive movements. That is, the brain is trying to calculate it in a different way. Suppose you want to go near with your instruments, your hand has to go away outside. Suppose you want to take and tie the suture, your hands at the tip or the instruments at the tip should go away, but your hands have to come near. So these are counterintuitive movements. So as and how your laparoscopic journey proceeds and you become master of laparoscopy, your intuitive movements have to go up, your counterintuitive movements have to come down. I'm clear? So just see this video as to how intuitive movements go up and your counterintuitive movements go down. This is a partial nephrectomy wherein a underrunning of the vessels is being done. Both external view and internal view is there. See how a hand of the right side is being rotated. See how a needle is being held and again taken in rather than taking away, and see the knotting how it happens. See the rotation. It should happen in an intuitive way, not by pushing the entire hand up and down, but rather just by rotating at your elbow. The rotation should happen. Pronation, supination should happen, not the entire arm movement. And see the tying of a knot. This is intuitive movement. Inside out is an intuitive movement rather than away from each other. So your intuitive movements have to increase, your counterintuitive movements have to go down. Hope I am able to convey what I wanted to convey.
Yes, sir.
See one more suture, just a rotation at the elbow, pronation, supination. One more bite. See the rotation happening outside with their with on the left side of the screen, and see the needle coming out comfortably just with the rotation. And see the tightening of the knot how it is done. There is no this way that way movement. It is all inside out movement. See that? It is inside out movement. Making the loop and tightening happens inside out. That is, your right hand is going in, left hand is going out. It is not both the hands going sideways or towards each other. Your counterintuitive brain tries to decrease counterintuitive movements, increase the intuitive movements as and how the laparoscopy matures. All right. So what all are the requirements to do or excel in laparoscopy? One needs to have a good team. Suppose you have mastered everything. You have got a nice table which is at your pubic symphysis. Supposing you have made a proper port placement, pneumoperitoneum is created. You have made an angle of 60 degrees. Half of your instrument 15 centimeters inside, half of your instrument is outside. Everything is fine. Lighting is optimal. Your monitor is at your eye and below. Everything is fine, but your assistant who is assisting you today is not there tomorrow, somebody else assists. Every case somebody new assistant is coming, you will get irritated because he is your eyes. He will show you, you want the lower pole to be seen, he will show you the upper pole. You want the ureter to be seen, he will show you the bladder. So that should not happen. You should have a team. The same team should be keep on changing. Supposing somebody is holding the camera, the same person should be doing the surgery next time. Somebody who is doing the next time will again come back and show you the camera. So the sync has to develop between the assistant surgeon and the surgeon who is doing the. So always develop a team to do laparoscopy, and you need to have a lot of patience because you will get irritated. Things don't move. It goes on very slowly. First pyeloplasty might take 2 hours. First nephrectomy might take 3 hours. But you need to have patience. You need to sacrifice and money, buy good equipment, and face some poor results. Initial pyeloplasty might leak, initial nephrectomy you need to convert, but face some poor results. Do not worry. Kill your ego. Call some senior, call some junior who is doing good at laparoscopy. Learn from them or ask them to help you in initial few 10-15 cases, and then start mastering it. And somebody else is doing better unless until otherwise proved. So don't think that once you have mastered, you are doing the best. There is still something to learn from every case when somebody else is doing or you yourself are doing. And always have a proper mentor and always have a good case load. That means if you do a pyeloplasty today, don't have a next pyeloplasty after 2 years. You should have a regular pyeloplasty being done every 1 month or every once in 15 days to have a regular improvement in every case that you do. Hope I have conveyed what all I wanted to convey. Any questions? You are all welcome.
Thank you, sir. It was a wonderful presentation. We don't have any questions in the chat box. So, any questions from the house?
Yeah, somebody has asked for axial holding. That is
Yes, sir.
long
Yes, sir.
axis. If you are holding the instrument by the long axis of the needle hole, that means a straight needle holder. You need to decrease the height of the table because you are going to hold it from above. The axial needle holder will not be held from below like a pistol, but you will be holding it from above. So you are already lifting your elbow away from. So to decrease that, the OT table height has to go down. You are right. Your
Thank
OT
you, sir.
table has to go down whenever you are using an axial needle holder.
Yes, sir.
Yeah, Saurav, it is a inferior epigastric injury only. Yes, please.
Sir, one more question. For upper polar kidney tumor, which axis is better? Transperitoneal or retroperitoneal?
See, people who have trained themselves or who have learned doing retroperitoneoscopy, anything posterior onto the kidney, they comfortably do it posteriorly. But still, I prefer transperitoneal approach for any any tumor onto the kidney. But preferably, if it is a lower polar tumor on the posterior aspect, retroperitoneoscopy is always better because bang in front of you, you will have a tumor. But upper polar tumor in retroperitoneoscopic approach to reach that upper pole is quite difficult. So what we do is we go transperitoneally, flip the kidney. The upper pole becomes lower pole becomes upper pole. So you can see the upper pole facing you while doing your partial nephrectomy. I do majority 90% of the surgeries transperitoneally only. Very few we do wherever there is a battlefield abdomen previous surgeries. That is when a retroperitoneoscopic approach we use. Otherwise, regularly it's
Yes.
transperitoneal.
Any more questions from anyone? So, if you don't have any more questions, we will conclude the session.
So, thank you very much, Dr. Ghouse, for
Sir,
sparing time. And in fact, it was a very beautiful lecture. In fact, I personally learned a lot of points which I have been conventionally ignoring. It is nice, in fact. It was very.
thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. It was a wonderful presentation, sir. We all learned a lot from that.
I
Thank
believe
you, sir.
we can post this in YouTube as well.
I regularly do this, program, sir, which is known as MUST, Minimal Access Urological Surgical Training. Every 3 monthly we conduct it. So this time in
Okay.
June 12th and 13th, we have got this program, and you just need to register on the website of AINU
Must, eh?
under training. Yeah, MUST. So under training, you can just go and register there. Some of the company guys will get in touch with the persons who have registered, and rest of the thing is taken care by them. We just need to come for 2 days and go back. All these things will be discussed, and we take everybody into the OT and demonstrate around 15 to 20 cases laparoscopically, lower abdominal surgeries, upper tract surgeries, partial nephrectomies, reimplants, VVFs, all are done in 2 days,
Oh,
around 15 to 20 cases, and one real hands-on view. We do chicken pyeloplasty also. We have got 4 5 endo trainers on which chicken pyeloplasty can also be done.
age no bar to joining. Age no bar for joining.
Sir, no bar at all. And you need to be a urologist only, nothing else.
Thank you, sir. Thank you very much.
Thank you so
So
much.
we'll conclude the session for the day.
Yeah. Good night,
Thank
everybody.
you, sir.
Thanks for
Thank you, sir.
joining. Thanks for
Yeah.
joining, everybody. Bye bye.
Good night, sir. Good night.
Good
Thank
night.
you.
Good night. Bye.